Welcome all to our Illuminate Speaker Series today. It is my pleasure to introduce Dr. Antonio Sarmento. He is a physical therapist with experience in respiratory assessment, intervention, physiology, and mechanics. He is currently a postdoctoral fellow at RespirabilityLab under my supervision, conducting research in the field of virtual care for individuals with chronic lung diseases. He is currently involved in 3 distinct projects that investigate the relationships between physical activity and symptoms in post-COVID syndrome, the effect of a self-management program for post-COVID using wearable biometric technology, and also in a different project that explored the feasibility of pulmonary telerehabilitation and telemonitoring for individuals with COPD. Welcome, Dr. Antonio, and please share your screen whenever you are ready. You are muted.
Yes, thank you, Diana. Thank you for the presentation. Just sharing my screen. Are you already seeing? No. All right.
No, we can't see it yet.
Let me see. Oh yeah, now I can share. Okay. Can you see now?
Yes, it looks good.
Thank you very much, Diana, for the presentation. Thank you for everybody present here today. I'm going to present one of the papers that we are writing right now. That's called Embracing the Idea That Less Could Be More in Post-COVID-19. So as I said, this is one of the studies that we are writing this time, and this will be focused mainly on physical activity and symptoms in this population. So I will pass here with you guys today, with everybody today, on the introduction, methods, results, and key messages of this study, and the implications for healthcare providers and for rehabilitation of these individuals. Post-COVID syndrome is a complex multi-system condition that may last for years and severely impair the lung function, the functional capacity, and quality of life of individuals. This condition is characterized by the persistence of symptoms for more than 3 months after the acute COVID-19 infection. Of all the symptoms reported by these individuals, the most common are fatigue, shortness of breath at rest and during activities, cough, chest pain, and dizziness. And some of these individuals, they also report a condition called post-exertional malaise, which is the worsening of symptoms after a physical exertion. This post-exertional malaise drastically reduce the ability of these individuals to be physically active, which consequently may also worsen the symptoms that day and the following day. So literature still lacks studies with associating the physical activity of these individuals with the symptoms, the intensity of symptoms, either that day or the following day. So therefore, in this study, we investigated the associations between daily physical activity, here expressed as number of steps per day, and symptoms reported in the same day and the following day in individuals with post-COVID syndrome. We also explored the same associations in the participants with and without post-exertional malaise according to the Canadian criteria. This was a longitudinal exploratory study, which was accepted by the Research Ethics Committee of the University of Manitoba, and all participants that contacted us were screened for eligibility via telephone. We included only adult individuals with persistent symptoms for more than 3 months after COVID-19 infection, with internet and access to a smart device, either a smartphone, tablet, or computer, and able to perform activities of daily living. Those who reported acute lung or heart conditions, who had hearing or visual impairments, and were unable to complete basic tasks on a smart device, were excluded from our study. So after the eligibility call, when they contacted us, after the eligibility call, if they were included in the study, they were invited to go to Riverview Health Center to take part of an assessment that lasted approximately 2 hours. During this assessment, we assessed lung function using spirometry, dyspnea using the modified Borg scale, fatigue using the fatigue severity scale and the pulse symptom questionnaire, and functional capacity using the 1-minute sit-to stand and the 6-minute walking test. From all these assessments, the lung function, the dyspnea, the functional capacity test, and the fatigue using the fatigue severity scale were used just to characterize our sample. For us, the most important of the assessments was the pulse symptom questionnaire, which was used to screen for post-exertional malaise. This questionnaire has 14 symptoms divided into 8 domains, and these symptoms are assessed by means of frequency and severity using a 5-point Likert scale from 0 to 4 points. So after filling the pulse symptom questionnaire, we started to include the Canadian criteria to assess if this participant fulfill the criteria for post-exertional malaise or not. This Canadian criteria indicates that these participants, they must have a 2-2 threshold. What is a 2-2 threshold? It's 2 in fatigue, 2 in frequency and 2 in severity of that symptom. So they must have a 2-2 threshold on the domains of fatigue, post-exertional malaise, unrefreshing sleep, and neurocognitive impairment, and the same threshold in one symptom from at least 2 of these 2 domains: pain, autonomic, neuroendocrine, and immune system. Just remembering that these are the 8 domains, and each domain has more than one symptom. So that's why these are mandatory, and the ones on the right are just one symptom from at least 2 of the domains. After performing all assessments at Riverview, we provided to the participant a wearable device. It was a smartwatch, a Garmin, and they should wear that smartwatch for 7 days. And every day, they should report the symptom severity from 0 to 10 in the smartwatch and using another apps associated, which were the Garmin Connect and LabFront Companion. So every day, imagine that every day, the participant wake up during the day, he or she could report the symptom severity once a day and using the LabFront Companion. And at night, when before going to sleep, they should synchronize the watch for us to obtain the data regarding number of steps and heart rate using the Garmin Connect app. So for us in this study, the variables of interest were number of steps and heart rate. And for that data to be valid, the participant should have at least 8 hours of recordings during waking hours. These waking hours were defined between 6 a.m. and 10 p.m. There is an asterisk here because 3 of the participants, including the study, they used to work at night shifts. So their waking hours was different, but they were included in our study. And for us to confirm that the participant was using the watch, the heart rate should be above 50 beats per minute. Because when you analyze the data, when we see the activity log, we could have number of steps as 0, meaning the participant was not wearing the watch or was seated, for example. But if the participant was not wearing the watch, the heart rate would be 0. So we knew that when he put the watch and heart rate started to go above 50 BPM, the participant was wearing the watch. That would confirm us that the participant was wearing. Okay. We used the chi-squared and the Mann-Whitney test just to analyze the sample characteristics. And for the main variables, which were number of steps and symptoms, we used the generalized estimating equations. This test was used to respond to 2 main questions of our study. The first was related to this first part here, which is, does the symptom reported by the participant today influence the number of steps taken today. And this association was adjusted by age, sex, and post-exertional malaise, yes or no. The second question was, does the number of steps the participant take today influence the symptoms that the participant report tomorrow? And this association was adjusted by age, sex, post-exertional malaise, and also the symptoms reported today. See that here post-exertional malaise was included in the statistical analysis as a dichotomous variable, as 0 and 1. That would not give us much detail of what was happening in the participants who actually had the criteria for post-exertional malaise and those who did not. So we explored more the data by detailing the analysis and performing the same analysis with participants just with post-exertional malaise and those without post-exertional malaise, and which was the one that I included here. And the question was the same as before. Does the number of steps today influence the symptoms tomorrow? Always adjusted by the same variables. So significance here was set at a p-value of 0.05, and all analyses were conducted using the SPSS software. Before I continue, I would like to know if anybody have questions about the protocol. Does anyone have? Because now I'm just talking about numbers. I can make a reassume now before continue if you guys want. Is everything okay? Okay. So just reassuming, participant woke up today. During 7 days was wearing the watch. He woke up, he could include the symptoms any time of day. And at night, the participant synced the watch to send us data about the number of steps and heart rate. All that for 7 days. Regarding the results, most of the participants were males and with overweight or obese, according to the BMI. All of them, the mean of all of them, the wearing time of all of them was around 14 hours per day. And we saw, after analyzing the data, that the steps taken per day, the lower and mid tertile, were within the range for sedentary, which is below 5,000 steps per day. The higher tertile of the steps taken per day was in the limit between sedentary and low active. Here I have the associations between symptoms the same day and physical activity. It has number of steps the same. I want first everybody to pay attention just in the upper table. The upper table, we have 4 columns. The 2 first columns are related to the associations between symptoms and number of steps the same day, adjusted just by age and sex. The one on the right are the same symptoms, association between symptoms and number of steps, but adjusted by age, sex, and post-exertional malaise. As you can see, not much change between them. The significance remains, but we don't have much detail of what happens with those who have and who have not post-exertional malaise. Now, going to the table below, we separated the individuals and analyzed the data just between those who had post-exertional malaise and those who did not have post-exertional malaise. When you analyze that in more detail, we see that shortness of breath at rest, shortness of breath during activity, cough, dizziness, and fatigue, they are associated with the number of steps in the same day in the participants who had the criteria for post-exertional malaise, which was different from the ones who did not have. So here, as we can see, analyzing the odds ratio, the lower the symptom intensity, the higher the number of steps. That was observed in all symptoms but shortness of breath, or of shortness of breath at rest, different from the ones who did not, which they have just 2 symptoms as significant. Now, here I have the associations between physical activity and symptoms the next day. Okay, first I want everybody to pay attention just in the table on the left side, in which you have the associations between the number of steps today and symptoms the next day, but just adjusted by age, sex, and the symptoms today, okay, which is represented here as symptoms the previous day. So, as we can see, the number of steps, the mid and higher tertile, are associated with shortness of breath at rest, shortness of breath during activity, dizziness, and fatigue. Remember that here is just adjusted by age, sex, and symptoms reported that day. When I adjust the same analysis for those individuals, I control that for the individuals who had or had not the criteria for post-exertional malaise, none of the significance change. So we had that independent of having post-exertional malaise or not, the steps taken today influence shortness of breath at rest, shortness of breath during activity, dizziness, and fatigue tomorrow. As I said in the previous slide, we don't have much detail here. We control for post-exertional malaise, but we don't have much detail of what's happening in those who have and those who don't have post-exertional malaise. So we divided, again, the sample between just those who had post-exertional malaise, those who did not, and performed the same analysis. So here, just to repeat, we had the association between physical activities, number of steps taken today, adjusted by age, sex, and symptoms today, influencing the symptoms that the participant would report tomorrow. So when we divide, we see that those who had the criteria for post-exertional malaise, the steps was associated with shortness of breath at rest, during activity, cough, dizziness, and fatigue. But those who didn't have the criteria for post-exertional malaise, just the steps was associated just with shortness of breath during activity and chest pain. And see that it's a little bit inconsistent when we have the no criteria, because we just have the higher tertile associated with shortness of breath during activity, and here we just have the mid tertile associated with chest pain, different from the ones who had, in which the mid tertile and higher tertile were both associated with shortness of breath, just apart from dizziness. Key message from all these numbers: post-COVID symptoms may influence physical activity, expressed here as number of steps, within the same day and the following day. And even after accounting for post-exertional malaise, or even after controlling for post-exertional malaise, a slight increase in physical activity seems to have a positive effect on post-COVID syndrome symptoms. As a limitations of this study, the sample size was small and most individuals were sedentary, as I showed in the first table. And about the sample size, as we divided the sample in those who had and those who had not the post-exertional malaise, we had just one group with 7 individuals, so that would be a limitation. And the awake and active times while using the device were not standardized for all individuals. As a strength, we have that this is the first longitudinal study to assess physical activity using wearable device during 7 days, and the intensity of symptoms today and tomorrow during the 7 days and throughout a week in a daily basis. As implications, although the results may not indicate causality, the proper management of symptoms may help increase the physical activity in patients with post-COVID syndrome. And even in patients with post-exertional malaise, being active, even a little bit, may have a positive impact on symptoms in the following day. And these results are potentially valuable for informed education and further rehabilitation programs. Thank you very much.
Thank you very much, Antonio, for your presentation. I would like to know if there are any questions in the floor. Julie, Archie, go ahead, please.
Thank you so much, Antonio. That was most interesting. I do have a question, and that I was struck by the fact that that mid-tertile group with no post-exertional malaise had significant chest pain. How do you account for that? I mean, it was a small sample, I grant you, but I'm sure you have a hypothesis about it.
So, in fact, some of these we are still debating. We are still debating with me and Daniel yesterday and tomorrow, and today we're debating about it. The chest pain and I think the chest pain and cough, Justin, are the ones that are not clear yet for us. The shortness of breath at rest and during activity, and dizziness and fatigue, yes, it makes sense. But the chest pain, it was the only symptom that we are a little bit struggling to understand it, mainly in those who did not have post-exertional malaise. You were right in the wound, I think. I think it was the only one that we didn't understand yet how to account for that. And we think that the low sample size may have influenced these results, because here we had 18 clusters of individuals. We had in the statistical analysis 5 days of data for each individual, repeated measured data for each individual. And that could be, the number of clusters could be small for accounting any significant results, even in that with seven individuals.
Well, it means that you have to do more research, right? Which is
Exactly.
always good. I think this is, these results are really interesting and could potentially have a big effect on certainly what physiotherapists do with folks with long COVID. However, I mean, with only, that small sample, it's just sort of, possibly let's do it. So let's go for a bigger sample.
Yeah, and that, Julie, was just to explore, because we were thinking, okay, we had 18 participants, and that makes sense for us to show. But when we detailed the analysis, yesterday we were thinking, okay, do we include or we don't include? It is the first study. It is small, but let's see let's include that. We're just exploring that. So we're just to explore the results and show, hey, there is something here. So further studies, more patients.
A feasibility study. Good stuff. Thank you.
Thank you.
Thank you, Archie. Thank you, Antonio. I would like to mention that also same-day symptoms were associated with chest pain and dizziness. So it is also part of that can help us to clarify this difficult association. Sandra has a question. Please go ahead.
Thanks. Yeah, I just wanted to clarify your wording about a positive impact. So I think you said that if there was more steps per day had a positive impact on symptoms the following day. When you say positive impact, do you mean that there were more symptoms, or that the symptoms were positively influenced and so far there were less symptoms?
Good. Thank you, Sandra. The symptoms are lower the other day. If you see the OR, it is less than 1. So the higher the tertile, the lower the symptom the other day. I didn't include the beta here because it would be a lot of values and could confuse, but the beta of all of them are negative. So it's a negative influence.
So if they had more steps on Monday, they might report fewer symptoms on Tuesday.
Exactly. And it's interesting because the mid tertile, you have this association, and when you go to the higher tertile, the OR is even lower, which means that the symptom is even lower the other day. And it's interesting as well because these tertiles, when I showed the table 1, we have the mid and lower tertile within the sedentary number of, accounting for number of steps, and the higher tertile between sedentary and low active. So even those that are sedentary, if they do something, it's possible that the next day the symptom would be lower, low intensity.
So that kind of goes against the idea of this post-exertional malaise.
Yes.
Yeah.
And all literature, I think. I was talking to Diana these days and we were going like against everybody. Let's do it. And
Interesting, yeah. Okay,
Awesome.
thanks.
And I could like just complement one thing. There is a paper that just came out at JAMA last month. It was the first paper showing that the activity is good for part of the individuals, but they didn't account for post-exertional malaise, which would be interesting, like divide and see which of them were had a positive, let's say, benefit of the exercise. So I think we are still in the beginning of everything, and it is valuable to go against what is recommended till now.
Thank you, Sandra. Before we move into the next question, I would like to clarify here that we're talking about physical activity, no prescribed exercise, and that could also make a difference. Archie, please go ahead.
Yeah, that was the point I was going to make, is that, maybe it's resisted activity.
Mm-hmm.
Because if it's number of steps, that's, I mean, there's resistance. Thank you, gravity, but still. So, the prescribed activity would typically involve resistance. And so that would be another thing to investigate.
Yeah. I want to add something as well. The duration of the exercise and the intensity of this exercise or activity, if we're talking about activity and exercise. Yesterday, we received from a patient in another study that she said that we are studying also tachycardia, and then one participant reported to the RA that she could control the activity to not go like above 100 BPMs per minute. But even after controlling, she observed that if the exercise or the activity that she was doing was in a it was not very long, she will not feel worse later. But if that was long, for a long time, she would feel like worse. So 2 factors that add to that you said is the duration of the exercise and the intensity, exercise / physical activity, because they're different.
Thank you. Are there any other questions for Antonio? I don't see anything in the chat. Anything else you would like to add, Antonio? Or
I think I had everything.
You're done?
I was, it was the question just trying to add comments what I was thinking.
Okay, well, if there are no more questions, thank you all for joining us here today. And thank you very much, Antonio, for your presentation. And we'll see you in our next Illuminate Speaker Series. Thank you. Have a great day.
Everybody.
Bye, everyone.